Good day to everyone. This is the final part of my lecture concerning anemias and their approach in their diagnosis. My name is Dr. Christian Dominic Rosales. The third mechanism underlying the causation of anemia is a diminished production of red blood cells. The most common and important anemias associated with red cell underproduction are those caused by nutritional deficiencies, followed by those that arise as a consequence of renal failure and chronic inflammation. I'm going to start with an anemia arising from a nutritional lack, and the most common one is megaloblastic anemia. In megaloblastic anemia, production in the bone marrow of abnormal nucleated red cells known as megaloblast is characteristic. It is due to the dietary deficiency of faulty absorption of or increased demands for vitamin B12 or cyanocobalamin or folic acid or vitamin B9. There is retarded DNA synthesis wherein RNA synthesis remains unimpaired while cell division is restricted. When such a vitamin B lack occurs, bone marrow activity is seriously impaired. The marrow cells proliferate but do not mature properly, and erythropoiesis becomes substantially ineffective. Anemia will now develop, and the number of reticulocytes are reduced, and even the number of granulocytes and platelets are also similarly affected. Large hypersegmented neutrophils, wherein there are more than 5 lobes noted, is the earliest morphologic sign of megaloblastic anemia, and the MCV, or the mean corpuscular volume, is elevated or above 100 femtoliters. The marrow is frequently and markedly hypercellular as a result of an elevated hematopoietic precursors. And there's also observation of giant metamyelocytes and band neutrophils. Here is a peripheral blood smear showing to you the presence of ovalocytes, macrocytes, and hypersegmented neutrophils, as shown in the upper image. The bottom image shows to you the presence of megaloblast, and there's even presence of dysplastic red cells. Pernicious anemia is a specific form of megaloblastic anemia caused by autoimmune gastritis and attendant failure of intrinsic factor production leading to a vitamin B12 deficiency. The stomach does not produce intrinsic factor, perhaps as a result of an immune process directed against the stomach lining. Symptoms of anemia and a joint skin pallor and jaundice give a lemon yellow complexion or a sallow appearance. There is presence of atrophic or acute glossitis. There are also episodes of diarrhea and abdominal pain, and there are even central nervous lesions. The principal alterations in this particular area involve the spinal cord, where there is demyelination of the dorsal and lateral tracts. About 15% of adults above 65 years old have laboratory findings of a vitamin B12 deficiency. A deficiency of folate results also in a megaloblastic anemia. It is a product of a highly defective diet or of chronic intestinal malabsorption condition. Dietary issues are most frequently encountered in individuals who are chronic alcoholics, those who are impoverished, and the very old. This type of deficiency has also been observed in patients who receive anticonvulsant drugs, especially phenytoin, and those who take the drug methotrexate. Megaloblastic anemia in pregnancy is not rare because of the fetal requirements for folate, and thus folate is often encouraged. Folate intake is often encouraged for pregnant women. In any event, the oral administration of folic acid relieves megaloblastic anemia. Now let's proceed to iron deficiency anemia or IDA. It is a classic example of a hyperchromic microcytic anemias characterized by the presence in the circulating blood of erythrocytes that are smaller than normal or microcytic and poorly filled with hemoglobin. Thus, the central pallor has been markedly expanded. It is a blood condition that must be distinguished from the thalassemia syndromes. Iron deficiency is the most common cause of anemia throughout the world, and iron is required for hemoglobin formation. It is derived from the diet and absorbed in the GI tract. Common causes of iron deficiency are profuse menstrual loss in women and bleeding peptic ulcer disease among men. Iron deficiency anemia is also frequent in infancy and childhood in victims of hookworm parasitism. It is common in childhood because due to the very small amounts of iron in milk. Persons with iron deficiency anemia are pale but not jaundiced. Esophageal webs appear together with iron deficiency anemia and atrophic glossitis to complete the triad of major findings in a rare condition called as a Plummer-Vinson syndrome. Helpful serum markers for iron deficiency anemia detection are as follows. We have to check for serum iron levels, total iron binding capacity, and ferritin levels. Serum iron levels are a measure of the amount of iron bound to transferrin. Total iron binding capacity or TIBC is an indirect measurement of transferrin in terms of the quantity of iron it will bind. Meanwhile, ferritin is an intracellular iron storage protein and its concentration is equivalent to the total body iron stores. Here is a table comparing iron deficiency anemia versus anemia of chronic disease and its close differential thalassemia. Note that iron deficiency anemia has a high RDW value, a high TIBC value, as well as a high transferrin value. In contrast to thalassemia, iron levels are normal and high in the latter condition. Sideroblastic anemia is a refractory anemia defined by the presence of multiple or at least 15% or more pathological ring sideroblasts in the bone marrow. This kind of anemia will demonstrate a form of ineffective erythropoiesis, and it has increased levels of tissue iron. It also displays varying proportions of hypochromic erythrocytes in the peripheral blood. Here is a peripheral smear stained with Prussian blue. Ring sideroblasts are identified by the presence of bluish granules, as shown by the image. Now let's proceed to anemia of chronic disease. Anemia of chronic disease is a unique form of anemia. In here, the anemia is initially normocytic, then can become microcytic. They occur as a part of a chronic inflammatory disorder, an autoimmune disease, most especially rheumatoid arthritis, in renal disorders, or even cancer. Multifactorial causes such as shortened RBC survival and impaired erythropoiesis and iron metabolism underpin this particular condition. There is slightly shortened RBC survival thought to be due to the increased hemophagocytosis by macrophages and occurs in patients with inflammatory diseases. Erythropoiesis is impaired because of reduction in both erythropoietin production and marrow responsiveness to erythropoietin. Iron metabolism is altered as a consequence of an increase in hepcidin, which inhibits iron absorption and recycling, leading to sequestration of iron. In aplastic anemia, normally red bone marrow becomes fatty and yellow and fails to produce enough red blood cells, WBC, and thrombocytes. In some cases, the onset have been preceded by an exposure to irradiation, certain viruses, and organic chemicals such as benzene, insecticides, or a variety of drugs, most especially the antibiotic chloramphenicol. In aplastic anemia, it is a condition characterized by anemia, neutropenia, and thrombocytopenia. Complications of this disease must be treated, and bone marrow transplantation is the mode of treatment for those with compatible donor and provides a 5-year survival of over 75%. Elderly patients or those without suitable donors often respond well to immunosuppressive therapy. Complications of aplastic anemia are due to infection, bleeding, and problems of iron overload from repeated blood transfusions. Here is a picture comparing a healthy bone marrow versus one that has aplastic anemia. The bone marrow in aplastic anemia are described as a hypocellular bone marrow. Moving on to pure red cell aplasia, it's a type of normocytic normochromic anemia with severe reduction of reticulocytes and a marked diminution or absence of erythroid precursors from the bone marrow. Diamond-Blackfan anemia is a congenital form of pure red cell aplasia. A diagnosis of this disorder is based on the lack or near lack of erythroblast from an otherwise normal bone marrow. Chronic acquired red cell aplasia has also been associated with other conditions such as drugs, collagen vascular disorders, lymphoproliferative disorders of granular lymphocytes, infections, and even thymoma, which is a neoplasia involving the thymus gland. Myelocytic anemia is an anemia characterized by a normocytic normochromic form that occurs when normal bone marrow space is invaded and replaced by non-hematopoietic or abnormal cells. It is a form of marrow failure due to metastatic cancer, and other causes will include the myeloproliferative disorders, granulomatous diseases, and lipid storage diseases. The anemia in this condition will usually present as moderate to severe, is typically normocytic but may be slightly macrocytic. The shape of the RBC in the smears may display marked variation in size and shape, and bone marrow examination is confirmatory. Before I end this lecture, I would like to show to you this slide. Thanks for watching and take care.